unraveling this, and just I'll give you how to follow up the cases. In fact, I was lucky enough to see the beginning of the lasers. In fact, as Kamaljeet was lucky to see the lasers. We have seen the xenon arc lasers in our institution. I was from the same institution from where Kamaljeet was there. We used to do lot of fluorescein angiography, and we were having Clinitex xenon arc photocoagulator, which was a xenon arc photocoagulator to our rescue, which was giving not good results or bad results, but spot size was very big, and unfortunately that laser was not having any facilities for doing laser by indirect ophthalmoscope. You have to do a uniocular direct ophthalmoscope, and through that the delivery was there. I have used the Zeiss xenon arc white elephant. That was also not having a facilities of indirect ophthalmoscope deliveries. So very new facilities have come to your rescue. This was the initial phases where the laser was started, which was not laser exactly, it was the xenon arc photocoagulator, which was giving a bigger shock. Just to give you a brief history, it was the Mayor SHRIKANT 1949. He started with melanoma, in fact, choroidal melanoma. He did the xenon arc, but visible infrared emissions to the instance retina burn, but it didn't become popular. Next, please. It didn't become popular. Then there come the ND-YAG lasers. Now more often all of us are using double frequency ND-YAG lasers for our photocoagulation. In between, krypton red laser has also come, which come into the red beam, which is possible to do it lasers during the case through the hemorrhages also. Just a brief history about it. Now we come to our main topic, that is how to follow up the laser patient. Next, please. I'll skip this. These are the schedules that these patients should be recommended. Next. Yeah, back Jana. The laser patients should be followed as per the modified treatment. That as it is mentioned in modified ETDRS for diabetic retinopathy, the burn should be less intense, directly targeting microneedles, avoiding the foveal vasculature within 500 microns. The follow-up examination of these patients should be done at 3 months interval. As I mentioned, that optimum effect of the lasers which you will be doing, it you will get after 3 to 4 months. So these patients who is suffering with CSME, clinically significant macular edema, they should be followed up after 3 to 4 months after the laser photocoagulation. Next, please. After completion of the laser, patient put it on a topical non-steroidal. That is also controversial. People say that you should not put up any steroid because you want inflammation to occur. Then only the effect of the laser will be there. So the plain antibiotic drop will be enough. But yes, some people are putting up a non-steroidal anti-inflammatory drugs. The post-lasers usually seen after 2 to 4 weeks. To any untoward effect, patient should be assessed. Treatment generally 2 to 3 months. The patient should be assessed clinically and sometimes supplemented by fluorescein angiography. Monitoring of IOP is important because post-laser sometimes some peaks of raised intraocular tensions occurs. One should monitor this, otherwise the patient retina is all right but may land up into the primary open angle glaucoma or optic nerve is knocked down due to this. And last but not the least, a proper retinal charting is there. That is very important. You must keep all your records of your retinal laser prior consent of the patients, and then maintain the record. That is very important because during the lasers you can create a iatrogenic hemorrhages that should also be notified. Vitreous hemorrhage can also occur, that should be notified. As I mentioned, the importance of monitoring IOP, that is very important because many times patient can develop the glaucoma. Record keeping is important. Many times I have gone through the literature, there is no way they are mentioned that where you can assign your sittings, first sitting, second sitting and third sitting. So I think the sitting, instead of writing 1, 2, 3, 4, you can use an unconventional nomenclature like was alpha, beta, gamma, theta and delta. So the patient doesn't know that is third sitting or first sitting, but you yourself know that yes, this was your first sitting, this was your second sitting, and that helps in monitoring. That is very important. It is not there in any of the literature, but yes, we have seen somebody using it, and we are using that nomenclature, which will be of great help to us, in fact, as a ophthalmologist, not to the patients, and patient will not know that where we have skipped the area of one sitting or not, or though, and that is informative as far the record keeping is concerned. Next, please. That is very important, how to manage the patients of your proliferating diabetic retinopathy. Early PDR, usually if patient is non-pregnant, it should be followed up after 4 months. Moderate to itna, it should be followed 3 months. The severe the higher, severe the PDR, it should be followed with much lesser interval. Next, please. That's very important. How do you know whether your laser is working or not? The indication of regression is important, that the blunting of the vessels, shrinking and disappearances of the neovascularization. However, it will take time, but at least the phenomena is started. That will help you in coming to conclusion whether your laser and vessels are leaving, often leaving the ghost vessels or fibrosis or epiretinal membrane type of membrane is being formed. Next, please. To reduce the number of exudates, clinically sign of good successful laser is to reduce the number of exudates, stabilization and improvement of visual acuity, although it is not directly improvement, because visual acuity is dependent upon the disruption of external limiting membranes, which may not be associated, which may not get okay by doing laser photocoagulation. Appearance of the fibrous components on angiography, regression of neovascularization elsewhere. Presence of neovascularization mild is of not that importance. It does not mean that your laser is not complete as yet. Next, please. If the patient has already lasered, that's few points Dr. Manish and Dr. Kamalji has already mentioned, you should be very careful. Shows the active neovascularization, that you must look for the skip areas. That is very important. The neovascularization is not coming because hypoxic retina is still hypoxic. You could not make it anoxic so that the neovascularization subside. Treat the neovascular area directly, can try the direct lasers, but very careful that venules should not be affected. Extend the laser anterior to the equator. As I have already mentioned, some studies have come recently where they have done the wide angle fluorescein angiography, and they found the neovascularization mean reasons because of the mid periphery to up to the aura. There is still some lasers are not covered, so that should be properly covered either with your slit lamp delivery, or if required, you can straight away go for the laser indirect delivery process. It's very important if the patient is present with vitreous hemorrhage, because it may be either iatrogenic or whatever hemorrhage is there. Nowadays, undoubtedly, anti-VEGFs are there to our rescue. They can help us as far as the resolution of the vitreous hemorrhage is concerned. But you must, if you do the USG, if there is no retinal detachment, patient is asked to propped up, not refined the bed, giving the treatment. Many times this hemorrhage resolves. Next, please. If there is no signs of clearing and you repeat the RT, there is no RD, and the role of positioning is not of that importance, the patient should be asked that he should be prepared for this. If the hemorrhage is not clearing, the patient should be prepared for going for vitreous surgery. That one more point is another to mention, that of practical values. We called it visible lasers. If hemorrhage is obscuring, not to go for a good other laser photocoagulations, you do the rest of the area where the visible is there. Although terminology is being coined, that is visible laser, but that is for the fact that wherever you are seeing the retina is not properly lasered, you do the lasers, and by the time after 2 to 3 weeks, the hemorrhage wherever it is there, because you have almost completed 3/4 of the retina properly done, the rest of 1/4 hemorrhage clears, then you can cover the laser photocoagulation in that very area. Next, please. This is already being covered. Sub-threshold lasers and Pascal lasers are the new modalities of the lasers which has come to our rescue. They should be judiciously used. Now we finish up the